So our next step is to diagnose the cause of the dementia. We exclude the depression, delirium, and we diagnose the type of dementia. Most people that you'll see will be Alzheimer's or vascular or a mixture. And as I said before, maybe Lewy body and fronto-temporal. So let me just tell you about some of those features. The prototype is Alzheimer's. So when I'm seeing someone, I want to know, how did it start? Did it start from one day to the next? Or was it gradual? So what was the onset and what was the progression? Classically with Alzheimer's, it's gradual the whole way. It's very hard to actually pick the time it started. And it may be in retrospect that the family say, yes, well, we noticed there were some changes. Or it may be a certain event which highlights it to the family. Dad was always a great speech maker. And at our daughter's wedding, he lost the plot. He just couldn't do it. My wife used to organise the Christmas cards every year. She was so organised. But last year, she was a total mess. She just couldn't work it out. So it may be an event which gives the appearance of a sudden onset, but it may be the stress that reveals the cognitive decline. We say death usually happens within 10 years, but that's very variable. It depends what age it starts on. If you've got someone 90 that you're diagnosing, 10 years ain't bad. But if you're 60 when you're diagnosed, 10 years is bad. About 10% of people with dementia start before the age of 65. So we can think of several stages. Mild cognitive impairment. They notice some problems. There's some problems on testing, but they're functioning normally. Mild Alzheimer's. They're forgetful. There's objective short-term memory loss, repeating questions, starting to lose interests in hobbies, socialization. And now they're just not able to do the things they used to do before, managing the finances, driving, and maybe some word-finding difficulty. As the dementia progresses, there's progression of the cognitive deficits, language problems become more apparent, the frontal lobe functions, your organization, your planning, your executive center. When you got up in the morning and decided what you're going to do today, that was the part was planning your day. As you're processing this, your frontal lobes are very much engaged, hopefully. Okay. And now we're starting to get impairment in basic activities of daily living, things like dressing, washing themselves, forgetting to clean their teeth. Families are bringing in more community care, are thinking about how long can I manage at home? Will I have to think about nursing homes? And in the severe stage, we start seeing a lot more of the behavioural problems, which are the most stressful part of the whole dementia picture for families. Sleep gets disrupted, and there's total dependence for basic ADLs. The vascular dementia may be a single strategic stroke in, say, the thalamus, or multiple small strokes, and we see thickening of the wall of arterioles. There may not be a stroke. There may be decrease in circulation, or there may be hemorrhage, which causes it. So there's several types of vascular dementia. So these are pictures of pipes. I went to Google and looked for pipes with lagging. These are pictures of arteries in vascular dementia. And you see, essentially, that's what's happening. And that's how I explain it to my patients. You get a pipe with all the gunk being loaded up inside of it, and so the blood can't get through, can't nourish the brain as much. So there may not actually be an infarct. It may be less nutrition to the brain going through. And this is common in hypertension. It used to be called Binswanger's disease. Or it may be you get small infarcts which accumulate. Most strokes are silent. They're small and they're cumulative and leads to dementia. If you have that cumulative pattern of small strokes, that's multi-infarct dementia. But much vascular dementia is smooth and looks just like Alzheimer's in their trajectory. But if they have a lot of vascular risk factors, hypertension, high cholesterol, diabetes, claudication, history of coronary artery disease, then we're building a vasculopathic picture, and it's more likely to be that. And when we do particularly the MRI scan, we see a lot of deep white matter hyperintensities. And it's more inside the brain, not the cortical, but it's a subcortical picture. And the subcortical picture is they're very slow in their mentation. So it's a slowing of information processing. They have difficulty with retrieving information. You know, they can remember it, it's in there, they just can't get it. Whereas the person with Alzheimer's, they forget it. Even if you give them a cue, they can't retrieve it. There may be gait disorder, there's more likely to be depression, and the MRI scan may be typical. Here's one. And here we see a lot of these deep white matter hyperintensities, particularly around the caps of the ventricles. But the hippocampus, that's what the arrow is showing, looks quite plump. Whereas in Alzheimer's disease, we'd see a more atrophy of that. That's a coronal view. You get a report, which you rely on, and we disagree with the report maybe half the time. Radiologists are usually conservative, and they'll say normal for age. We look at it, we think, no, this is atrophic. And they say ischemic, or deep white matter hyperintensity is consistent with ischemia. But how significant is that? Without looking at the quantity, then it's hard to know, because everybody over 70 will have some deep white matter hyperintensities. The third most common cause is Lewy body dementia. And they have Lewy bodies in their brain, in the cortex, and they have a build-up of a different protein in the brain called synuclein. It's progressive, it's dementia, and the features which are different is, apart from dementia, they get fluctuations. Before we knew about this diagnosis, we thought people were having recurrent deliriums, but they have acute confusional states which resolve. We never found an infection. We could never find a cause. The other feature is recurrent visual hallucinations. About half the people get quite vivid hallucinations. People in the room, animals scurrying across the carpet, children visiting every evening. The last one was a woman, 85-year-old lady I looked after, and her main complaint was she prepared meals for these children, and they never ate it. She was not distressed by the hallucinations, but they were very vivid for her. They also have spontaneous features of Parkinsonism, mainly the bradykinesia and the stiffness. They don't usually get the tremor. And visuospatial and frontal subcortical abilities are lost. So they get lost. They get disorientated in new surroundings. Memory is not as bad as it is with Alzheimer's. Now, the importance about distinguishing this, if you've got a patient with dementia who gets hallucinations, and if they're distressing for the patient, you put them on antipsychotics. These people are exquisitely sensitive to antipsychotics. So they'll get the Parkinsonian symptoms in spades. So if you're going to use an antipsychotic, and it's not your first, shouldn't be your first line, then use one of the novel antipsychotics which has less in the way of extrapyramidal side effects, such as olanzapine or Seroquel. The other features they have is their repeated falls. As I said, the neuroleptic sensitivity, they can have systematized delusions, and they have REM sleep behavior disorder. So when we're in REM sleep, we can have quite violent dreams. We can be running, we can be hitting, we can be doing all sorts of things. But our motor system is paralyzed. Part of the brain disengages the thinking from the motor system. In REM sleep disorder, that off switch is lost. And so people may act out their dreams. And partners complain, he hits me during the night, or he goes walking and doing all sorts of things like that. That's a REM sleep disorder. And that's quite a feature of Lewy body dementia. Fronto-temporal dementia is less common. And there are two main variants, behavior and language. So what we see is atrophy, and where? Well, in the frontal and temporal areas. Most neurological diseases now, many neurological diseases, are an accumulation of an abnormal protein which is toxic. And the accumulation takes many years before it becomes a clinical syndrome. In Alzheimer's, it was the A-beta protein. In Lewy body, it was the synuclein protein. In Huntington's, it's the Huntington protein. In Parkinson's, the Parkin protein. In frontotemporal dementia, it's either the tau protein or something called progranulin. And there are two main varieties. It's frontotemporal dementia is more likely to have an autosomal dominant inheritance. It's linked to some other diseases. About 5% of people with motor neurone disease develop a frontotemporal dementia. It's also linked to corticobasal degeneration, and there's a rarer type linked to Parkinson's disease as well. So putting that into a context, here's frontotemporal dementia. There's a behavioural form where people are disinhibited, overfamiliar, jocular, often comes on earlier. So our very first patient when we opened our memory clinic in 1985 was a man in his 50s. And he'd had a year of psychiatric treatment for this strange behaviour. Well-educated man, 3 teenage boys at home. The family was in a mess. Psychiatric treatment had been complete failure. And mini mental state was good, but when we did more detailed testing, his frontal lobe was shot. And on MRI scan, we could see some evidence of that as well. And he passed away in a psychiatric hospital in Bloomfield. No, sorry, Morisset some years later. Behavioural problems. Or it could be language problems. People lose the meaning of words or lose the ability to string words together. Other features are people have this stereotyped eating pattern. So one woman I saw who would only eat fruit salad and ice cream 3 times a day. That's all she'd eat. Or another woman who was a woman in her 50s, top-notch lawyer, fitness instructor as well. She stopped doing fitness work. She's just pigged out on chocolate. She went from being svelte to being obese. Another woman I saw, an older woman in her 70s, she could not stop gorging herself. And in fact, the family had to stop her choking to death because every time she saw food, she would just stuff it in her mouth. Eventually, they put her in a nursing home. She had a 1-to-1 special. One day, somebody came along with a tray of sandwiches, and before the nurse could do anything, she grabbed the sandwiches, stuffed them into her mouth, and she choked to death. But this hyperphagia, hyperorality, can be a feature of frontotemporal dementia, as can hypersexuality. So frontotemporal dementia often presents earlier, and patients under 65 with strange behaviours think about it.